Cavernous sinus has a unique anatomy because it is the only anatomic site where an artery passes through a venous space. Thus, creation of an arteriovenous fistula requires only rupture of the artery and not simultaneous trauma to adjacent parts of an artery and a vein. This picture depicts the tributaries and draining channels of cavernous sinus. Carotid cavernous fistulas can be categorized according to pathogenesis as direct or indirect, and based on hemodynamic profile, high flow or low flow, and based on angiographic anatomy. Barrow's classification scheme based on angiographic anatomy is most widely used as each type has a characteristic vascular supply which determines the therapeutic approach and also predicts the outcome. Barrow's type of fistulas are direct communication between the internal carotid artery and the cavernous sinus. Barrow's type B, C, D are indirect dural shunts because these fistulas arise from dural arteries and not directly from internal carotid arteriovenous. Type B fistulas are between meningeal branches of internal carotid artery and the carotid sinus. Type C fistulas are between meningeal branches of external carotid artery and the carotid sinus. Type D shunts have connections between meningeal branches of both internal carotid artery and external carotid artery. Next, coming to pathophysiology of CCF. If there is retrograde flow anteriorly that is towards superior and inferior ophthalmic veins will cause symptoms such as dilated orbital venous spaces causing congested orbital soft tissues and muscles leading to arterialization of conjunctival and scleral vessels causing chemosis along with cranial nerve palsies. Patient can present with ophthalmoplegia due to involvement of cranial nerves 3, 4, 6, ptosis due to third nerve involvement, relative afferent pupillary defect and decreased vision due to second nerve involvement. Instead, if there is retrograde flow posteriorly that is towards meningeal veins, example sphenoparietal sinus, that is to superior and inferior petrosal sinus can lead to dilated cerebral venous spaces causing disorientation, ischemic signs and symptoms, cortical and brain stem dysfunction. Dysfunction. Presentation of patients in direct CCF is usually acute onset with overt signs and symptoms. Usually present with classical triad of chemosis, pulsatile exophthalmos and ocular bruit. Indirect CCF have gradual onset with milder presentation.